Is it possible and sustainable to provide free, quality healthcare to everyone who needs it, respecting human rights and ensuring the dignity of every individual? In countries affected by conflict and poverty, there is a serious need to rethink the models of international cooperation in the health sector. This panel aims to bring together international health and development experts to question the idea of two-tier medicine in favour of more comprehensive approach for an equal access to healthcare for all. So I would like to introduce our speakers. We have Dr. Ahmed Al-Mandhari, the World Health Organization's Regional Director for the Eastern Mediterranean. And Dr. Al-Mandhari, where are you joining us from?
From Cairo.
From Cairo, lovely. Thank you so much. We also have Dr. Paul Farmer, who joins us from Boston. He joins us in his capacity as co-founder and chief strategist of Partners in Health, an international non-profit organization driven by the belief that healthcare is a universal right. Hello, Dr. Paul Farmer.
Thank you for having me.
And also we are joined from Milan by Rossella Micio, who is the president of Emergency, an NGO offering free medical and surgical treatment to the victims of war, landmine and poverty, alongside and training local staff. And this panel is partly in thanks to the partnership of that organisation, Emergency. Hopefully we will be joined by another panellist as well in Uganda. I think some slight technical difficulties there, which of course we can forgive. This is a technical feat of genius getting everybody together in this virtual way. So hopefully she'll be able to join us in a few minutes. Rossella Micio, I wanted to start with you. It was your organisation, Emergency, that set up the African Network of Medical Excellence. Firstly, how many countries are involved? What's the model? How is it different?
Good afternoon, everybody. 10 countries signed the Manifesto for a Basic Human Rights Medicine that was the basis of the development of the African Network of Medical Excellence. The idea was very simple, was to identify health priorities, health gaps in these countries, and then establish centers of excellence in each country in the different specialty, and then have them working as a network, both in terms of patients referral, but also in terms of training of the medical staff, and also developing joint research programs and sharing the medical knowledge. And this was a model that we identified as feasible and badly needed to fill the gaps that we identified to strengthen the health systems in Africa.
So localized healthcare systems, and what was the inspiration?
Well, actually, the first experience was the Salam Center for Cardiac Surgery that we established in Khartoum back in 2007 with the idea of providing these very specialized services, cardiac surgery, not only to Sudan patients, but also to the patients coming from the neighboring countries. And actually, we have been operating on patients coming from more than 30 countries. And therefore, from that experience, we decided to sit around a table with the ministries of health of the countries involved, trying to understand if this could be a model, a replicable model, something that they would be interested in, and how to develop it jointly together, because it was supposed to be, and it is, a joint effort of NGOs, local governments, international bodies, and community. It cannot be just a one or two single actors approach and initiative.
So it's a model that can be replicated across many different countries instead of random, if you like, individual clinics with different partners and different funding. And Dr. Paul Farmer, you have experience down on the ground in Haiti, for example. You've seen there the poverty, the lack of healthcare. From your perspective then, can this model centered around these centers of excellence, can they really tackle key health gaps in low-income countries?
Well, you know, my experience is that not only can they do so, it's really one of the best ways to address really complicated health problems. We've worked with emergency, for example, in settings where, you know, if you open your doors as a clinic or a hospital, you know, pretty much anywhere in what, you know, just to use a metaphor, might be called a medical desert, you're going to see patients, a lot of them very young, coming in with all kinds of problems. And, you know, the first time you see a child come in with a, you know, heart valve disease who's gasping for breath, and the idea of having nowhere to send that child is a crushing defeat, obviously, for the family and the patient, but also for the caregivers. So, you know, having these centers of excellence that can lift up aspirations is an important contribution, well beyond the number of patients that could be seen in a center like Khartoum. We've also sent patients there, by the way, from Rwanda. And what we've done in Rwanda, working with the same approach with the ministries of health, with the you know, folks like Dr. Ahmed in WHO, is to establish centers of excellence. In fact, we've even done it in rural areas, rural Haiti, rural Rwanda, rural Malawi, rural Lesotho, because for lots of reasons. One is that many Africans live in rural areas, but another is that is the most desiccated part of the clinical desert, and you know, lifting hope can lift hope across entire nations. So I would even put it this way, Luisa, my experience is that this is the best way really to propagate excellence, especially in this in the post-colonial setting where, you know, for so long there were no aspirations to excellence locally. There wasn't even attention paid to proper care for the natives, as they were called under colonial rule. So we're making up for lost time as well.
But does it really cater for even more distant, marginalized communities? I mean, you talk about these centers really filling a gap in a clinical or medical desert, and it sounds fantastic. But what about outreach for those people who can't even get themselves to these clinics for all sorts of reasons?
Yeah, that is really the key question. One of the reasons that this model is linked to not just to other district hospitals, as they're often called across the world, that is a local regional hospital rather than a referral center of excellence, but also to clinics and communities through community health workers. And I can just tell you, if we send a child, you know, from Rwanda to the Sudan for a valve replacement, depending on the kind of valve that's used, that child may need anticoagulation with a medication that has to be taken every day, so that a lot of good surgery probably ends badly because of the lack of follow-up. So implanting these centers of excellence into national healthcare delivery systems is the key. In northern Rwanda, and we have established a center of excellence for cancer care, and it's again in a rural area. When I was just back there in the height of the COVID pandemic, I asked, well, what happened to the patients during the shutdowns, and found that, you know, they had all been found in their home villages, and if necessary, brought back up for their chemo or whatever, or their therapies brought to them. That's what happens when you take this model that Emergency has been promoting and implant it into a proper national healthcare system. So I'm a true believer.
Okay, thanks, Dr. Farmer. Well, we can see Dr. Diana Atwine there has managed to join us from Uganda. Just waiting for confirmation that the audio channels are working as well. So, Dr. Diana, can you give me a thumbs up if you can hear me, please? Just waiting for Dr. Diana to put her microphone on.
Can you hear me now?
Yes, we can hear you now. Thank you so much for joining us from Uganda. We've been hearing about the centres of excellence that have been set up. Oh, and I think she's gone again. I think we've lost Diana. Well, hopefully we will be able to hear from her before the end of the session. But thank you for that, Dr. Farmer. And now, Dr. Ahmed Al-Mandari, I want to turn to you. And before I do, I just wanted to point out something that the UN Secretary General Kofi Annan said, the former UN Secretary General. He said, a rights-based approach to development describes situations not simply in terms of human needs or of developmental requirements, but in terms of society's obligations to respond to the inalienable rights of individuals. So, Dr. Ahmed, how can the international community contribute to ensure effective and concrete fulfillment of a rights-based approach to health?
Thank you very much, Louisa, for leading this discussion. And in fact, you know, I may start, as you all know, we live here in Eastern Mediterranean in a very dynamic and diverse region with a lot of challenges, you know, social, economic, and demographic challenges. And at the same time, I must say also, we share strong values of solidarity that promotes partnership, so that, you know, we are able to give a voice to those, if I may call them, voiceless. And just listening to Paul and Rosella, you know, is a true reflection of that sort of partnership, either between the UN agencies or between non-UN agencies. For us in WHO, a key priority is ensuring healthy lives and well-being of all here in the region and beyond. Our driving force for that aim is, as you all know, the SDGs in general, and SDG number 3 in specific when we talk about health and pure health-related issues. And these sort of you know, targets and goals are framed within something called General Program of Work number 13, which is guiding WHO in general at a global level, as well as regional and country levels. Here in IMRO also, we have added to that sort of driving force, the GBW 13, focusing on the SDGs, and SDG number 3 is the IMRO Vision. We call it IMRO Vision 2023, which is health for all by all, a call for solidarity and action. So to make sure that everyone in the Eastern Mediterranean region can enjoy a better quality of life, as you have mentioned. Now, at the heart of these sort of good, you know, sort of terminologies, we have something called the universal health coverage. And it is considered as one of the best tools within which we have the primary health care. This means that all people and communities and individuals in these communities can use the promotive, preventative, curative, rehabilitative, and palliative healthcare services they need of sufficient quality to be effective, while also ensuring at the same time the use of these services by those people does not put them you know, on financial hardship, as what is happening in many parts of the world. And here I must just mention, you know, the spirit that was carried by Al-Ma'ata Declaration more than 40 years back. And recently, 2 years back, Asitana, you know, in which we have all met, in fact, UN and non-UN agencies, Asitana Declaration at a global level. At a regional level, in fact, 2 years back, September 2018, we met in Salalah, Oman, in which we have had, you know, this Global Compact 2030 and Salalah Declaration to make sure that these sort of noble driving forces and guiding principles for us all as a UN agency are really implemented at a country and regional levels.
And
now,
Dr. Ahmed, sorry to interrupt you there, but to that point, in your experience, which actions should states prioritize in order to achieve the goal that universal access to healthcare is put in practice for everyone without discrimination. What should states be prioritizing?
Exactly. I mean, this is something that we have been working with member states and donors as well as UN and non-UN agencies by creating partnership. So member states are requested and asked, in fact, to prioritize actions on strengthening primary healthcare in general to make sure that people at the center or the peripheries of each country are getting access to a quality and high-level safe service, focusing on family medicine with its holistic meaning, introducing packages of essential healthcare services to make sure that every citizen is getting access to these services, facilitating and improving whatever payments that are supposed to be there for these services without putting any hardship or any sort of burden on the communities, and engagement of individuals and communities in their own healthcare services to promote their health, And then, as I said, partnership, strong partnership. That's why we call it health for all, by all. Health is no more the responsibility of the Ministry of Health. It is the responsibility of every organization, every individual in the community, and every authority, government and non-government authorities in each individual country.
Thank you. And Dr. Farmer, I guess you'd agree with that, because Partners in Health really believes that healthcare is this universal human right. But we are seeing that it is possible, but is that a very utopian view, if I can play devil's advocate? Because it comes down to funding, it comes down to training, it comes down to having enough people to even be able to help others.
Well, it's certainly utopian, but the alternative is, of course, to have a dystopian view of this, and that's very much what many are facing right now, a dystopia. I mean, that's what has led the three of us, and I'm sure Dr. Diana as well, into this work. This was a very troubled arena where, of course, healthcare is not functionally a right at all. So the utopia is necessary as a guiding aspiration, just like a center of excellence, to lift up our aspirations. But I would just say this: every effort to promote universalism is going to drag up the quality of care, as long as it is accompanied, as you just said, Louisa, by the right investments. And I want to go back to Rwanda, which has been a real standout on the continent, not just for its improvement, which has been stunning. In fact, looking at mortality data and life expectancy at birth, and following a number of pathologies, Rwanda has shown the steepest declines in mortality ever recorded at any time and in any place. And if you want to know why, you've got to know about their investments in a national healthcare delivery system. Emergency and Partners in Health are NGOs. They're by definition non-governmental. But when we can contribute to the efforts of a visionary, for example, government that is putting up to 20% of its public treasury into healthcare delivery, we're going to see big results. And when we can coordinate that in the manner that Ahmed said, we're going to see even more yield on these investments. And after all, it is governments, not NGOs, and not the World Health Organization, that can confer rights, right? The right to healthcare is not something that an NGO can waltz into a country and say, hey, we're going to decree that you have a right. This is the obligation of governments, as Ahmed said, and pulling together, and through collaboratives like the one that Rosella has described, we think is going to help make a difference.
Rosella, to that point, you've had to encourage governments and ministries to get on board. What are the constraints you found in establishing this model of the centers of excellence? Rosella, if you could put your mic on, please. Thank you.
Sorry. Yeah, I was just saying that I totally agree with what Paul just said. I mean, a utopia is not something that it's impossible. It's just a project that is not yet been in place. So we should just work towards it, and this is what we have been trying to do. Of course, the constraints are many. One is, let's say, constraints in terms of general approach when it comes to proposing to dedicate attention and allocate resources to medicine of excellence, because most of the attention and the resources are going to primary health care, or to just infectious disease, which is of course needed, but it's not enough if we really want to have a human rights-based approach. Because if we just limit ourselves to those sectors, it's like we are stating and acknowledging that there are different rights according to the place where you have born, when you're born, and this is something that we cannot accept. Therefore, it's first of all a change of mindsetting, of attitude, and then it's of course trying to find the resources necessary. But I think that the resources are there, both in terms of economic resources, knowledge, human resources, and actually this approach can trigger a positive fallout, a positive effect also to the other sectors of health system, and then result in an overall strengthening of the system.
Yeah, and Rossella, we were supposed to be joined by Dr. Diana Adwine from Uganda. We saw her, she disappeared. I don't know if we'll get her back. Oh,
I'm here, my dear.
She's here, brilliant. We can hear you, you can hear us, all is good. And perfect timing, Dr. Diana, because you, I wanted to ask you, the second centre of excellence in the network is due to be built in Uganda. You, from the Ugandan Ministry of Health's perspective, what encouraged you to want to collaborate on this project? And tell us a bit more about it. Dr. Diana, is your microphone on?
Yeah, I wanted to start from where Rossella stopped from. First of all, Uganda, as part of the African countries that has still growing, yet with a high disease burden. When we talk about infectious diseases, it accounts for over 60% of the cases registered in our hospitals. And then now also we are seeing now the lifestyle diseases, the non-communicable diseases on the increase, and yet they are very expensive to treat, as you know. Now, we have, first of all, as a state, we have to balance, we have to treat, we have to take care of the primary health care issues, we have to treat the infectious diseases, but at the same time also, we are now investing heavily in improving on the tertiary services. But now, as you know, in Uganda, we still have the big gap in funding for health. And so we are seeing a lot more diseases that are very difficult to treat, for example, out of pocket, and people are spending a lot of money to treat, for example, cancer, from heart disease. And now what the country is doing right now is to set up the centers of excellence so that we are able to offer these services for free. We have expanded Mulago. Now we have introduced, actually today I wanted to give you good news this morning. We have separated the Siamese, our doctors had carried out 20-hour surgery to separate the Siamese, where these Siamese were even conjoined all the way from the spine to the genital organs, to the bones of the spine, and they have successfully separated this. But it took a lot of work to invest in technology, to invest in equipment, to invest in infrastructure and human resource. We cannot say that we are there, but let me tell you, to offer universal health coverage, it has to be a multifaceted. We can't do it alone as government. That's why we are collaborating, for example, with emergency, and we welcome them so much because they are bridging the gap where, for example, the people who cannot afford can get the services for free. And we do believe that even if we really as government wanted to offer free services to everyone in the country, give free services for cancer treatment, give free services for surgery, give free services for maternal health, it cannot happen because we still have huge numbers of diseased community. Actually, right now, government is investing more money in prevention. We are now looking at preventive method as one of access to universal health coverage.
Diana.
Yes, please.
Thank you so much for explaining all of that, and very interesting to hear all the challenges that you're facing in Uganda, but that you welcome this new Centre of Excellence. Tell us a little bit about it. What's it going to be?
The Center of Excellence of Emergency is going to offer free services, free specialized services that otherwise would make Ugandan children fly out of the country and
so
go
it's
and
pediatric surgery.
Yes, please. And it is going to offer a wide range of conditions, gastrointestinal diseases, spinal diseases, the heart diseases, and so many. But otherwise, where those vulnerable people, where they would not be able to get their services and have their children die, these are people who are coming in the country to bridge that gap, to make sure that everyone in the country who deserves to be treated actually can access the service for free.
And having gone through this process, when will this Centre of Excellence be built? When are you expecting it to be up and running?
It was supposed to actually to open in April because of COVID. It was not possible, so we postponed it, and we hope, if all goes well, we are going to open it in January next year. But all is set, and we are looking forward to seeing this Center of Excellence fully operationalized.
Fantastic news, and let's hope that happens early next year. Having been through this process, going through it, which lessons that you have learned would you share to the benefit of future countries looking at replicating this approach? What lessons would you share with other nations?
There are three lessons that we have learned through collaboration with Emergency. The first one is that we do still have philanthropists that are really out there that are willing to support. So if we work with those people, they can actually expand the services, and we get more people who are vulnerable, who don't have any hope, and they can be given the chance to live. The second lesson is that we can actually collaborate, because I think before we don't have this kind of arrangement where we work with NGO, where a full government works with NGO that is able to give national services and set up a Center of Excellence and run it and give excellent services and sustain it. Number three, it is also an avenue for us to prioritize the skills that are needed. The emergency services is not only for this hospital, is not only for treating, but is also going to offer specialized training, especially nursing training in these key skills, because we don't have enough workforce. So we are also looking at this opportunity, and we know that this is possible, and we are going to build a big workforce that is specialized, and it can even, that service can spill over to other hospitals, because we will get the expertise and we take them also to other hospitals. And therefore, it will be the springboard for the improvement of care in the country.
Dr. Diana, thank you so much. We'd love to hear some questions from the audience. Please do submit your questions and I will put them to the panel. Just before I go to those, a question again to you, Rosella. You've got decades of experience running high quality hospitals from Afghanistan to Sudan. How can you ensure that the model of these centres of excellence that you're proposing is sustainable on a large scale and a long-term basis?
Well, I think that the key of the success and the long-term sustainability is the involvement of local authorities and the local community. Because at the end, as Dr. Diana was saying, I mean, we are just partners coming to help and support, but definitely the final owners are the local communities. So, and I really think that when it comes to providing quality services that are patient-centered, this makes the difference also in terms of engaging the local authorities and the local communities. We have seen it everywhere. I mean, the hospital in Sudan, as the one in Uganda, but also the one in Afghanistan, are supported by the local ministries of health, also in terms of funding, which is something quite incredible, if you say, but it's true, it's real, it's not utopic, it's the daily practice. So when you work in a real partnership and share the same aim of strengthening the local health services with a quality approach, then I think that resources can be mobilized and people also feel more, let's say, convinced to be part of a project.
Thank you, Rossella. And Dr. Farmer, do you have some ideas then how we can ensure these centres for excellence are going to be there for years to come and in many different nations?
Certainly, and my experience is very, our experience rather, is very, very similar to that of what Dr. Diana described and Rossella as well. I mean, just to give an example, in founding the Center of Excellence that I mentioned in northern Rwanda, not far actually from the Ugandan border, you know, Partners in Health built in 15 months a modern hospital, but for the government of Rwanda. It is a Ministry of Health hospital, just like the big one we built in Haiti after the earthquake, right? And within about a year of opening that hospital on government land, the Ministry of Health and other parts of the government were paying over 70% of the salaries of the staff there. And you know, it's not, when we use the word sustainable as an adjective, like something is a sustainable or not, it's often to get us away from the utopian vision that we need to pull us forward. The question is, can we sustain it? And here we are 10 years later, that that Center of Excellence is growing. And again, the government, largely the Ministry of Health, but other branches as well, have been so excited about this progress, which they regard rightfully as Rwandan progress, that they've helped us to establish a university in that same formerly rural area to focus on what Diana describes as a need, which is building up the workforce that was never built before during colonial rule. And I'm sorry to keep going back to colonial rule, but it's amazing to me that, for example, in Sierra Leone, where the British could have been there over 2 centuries, they didn't even build one medical school or a nursing school. So again, that's why I think it's important to say we have a lot of catching up to do.
Well, that's interesting. You talk about that colonialism, because we've had a question in from the audience, which is to you, Dr. Farmer, which is, are there colonial artifacts left baked in the infrastructures of African countries that are obstacles to health delivery? And from what you've just said, it sounds like the fact is that nothing was done to help the health care in these countries.
Well, something noxious was done, you know, and I'm not disparaged. I'm sure there were many good things done as well. And I'm sure there were some visionary colonial health officers. You know, you can read their biographies, no doubt, or their autobiographies. But what was done that was noxious was to knock down people's aspirations inside, for example, post-colonial governments, and in which it became considered utopian to try and do anything that would rival the kind of basic services that are taken for granted in other parts of the world. So although there aren't many victories from colonial medicine, there was some damage done. And I think that's why I've always been a supporter of emergency, because, you know, from the beginning, when a kid steps on a landmine, you know, in Afghanistan, and if there's a team there to say, no matter what has happened here, we will do everything possible to put this child back together. That's the kind of utopian vision that we need to lift up, you know, health, to lift up the fight against health disparities. And that's why I keep going back to Rwanda, because on a national level, they've moved forward that ambition.
Thank you, Dr. Farmer. We've had a question in: how has the global pandemic made you reassess the different factors that could impede building the Centre of Excellence network? But I guess that could also, you could give your thoughts about how it's affecting the improvement of healthcare generally. And Dr. Al-Mandhari, would you like to answer that? How COVID has affected the situation from your perspective at the World Health Organization?
Yeah, thank you, Louisa, for this important question. In fact, I must say that this pandemic is like, you know, a big shake to us all on Earth. You know, either when it comes into healthcare leaders, professionals, decision makers at different levels on different sectors, including the political leaders. It showed us how strong our healthcare systems, but the most important thing that it showed us, if I may call it, you know, how weak our healthcare systems when it comes into facing such global pandemic. As we have seen it, you know, many countries, not only low resourced or middle income countries, but countries which were considered as having the best healthcare systems, went into a very serious, you know, crisis in terms of making sure that healthcare services for this pandemic in specific are made available on time, with minimal loss of lives and minimal cost on the healthcare system and the financial cost, I mean, but also to make sure that whatever other healthcare services that are needed by a wide range of people in the community, children, adults, men, women, are made available, which was not really, which we did not succeed in that. So this pandemic showed us what opportunities that we should really make use to improve and strengthen our system, to make them more resilient in case we face similar scenario in the future. At WHO, there are three levels, or three types of committees that have been established and led by top political and technical leaders to assess and evaluate how WHO reacted, to this pandemic, and how member states reacted to this pandemic, as well as other agencies, have reacted, and getting the lessons learned. So hopefully we will learn the lesson, and we will make sure that our systems are well improved and becoming resilient for whatever shake in the future, regardless of its scale.
Thank you, Dr. Al-Mandhari. Any other thoughts from the panel then on COVID?
Well, if I may add something from our direct experience on both sides, let's say here in Italy, which was one of the countries, the first country actually in Europe affected by COVID, and then the other countries where we're working, we immediately realized that one of the major problems to face was how to guarantee the continuity of COVID, of healthcare for non-COVID patients, because if this was an issue in Italy, where the health system is well structured, can you imagine in a country where the health system is much more weak? Therefore, the first thing we did was really to protect all our facilities worldwide with the training in IPC, procurement of extra DPI and so on. And this allowed us to stay open all through the first wave of the outbreak, and even now, fortunately, in countries where there is an acting war, like Afghanistan, but also in Sudan, for example, where we were the Salam Center, the only center for cardiac surgery that was always open and providing life-saving treatment to the patient. So this means that also when it comes to sudden, unexpected emergencies, perhaps there is something more that we can do to protect the entire community and to make sure that these new diseases do not affect additionally all the other situations that are already there. So definitely, I welcome very much the efforts also in WHO to revise and to discuss, because this is really something that we have to think about a lot for the immediate future and for the long term.
Yeah, thank you. And Diana, are you still with us? Is Diana still with us from Uganda? No, I think she has dropped off this call. So just one last very brief question. Dr. Farmer, do you feel that the model can be transplanted in other places, in war-torn countries? This would be hard, but needed the most. Well, I guess this is what the Centres of Excellence is aiming to do as well. Very briefly, please, Paul, as we're running out of time.
Thank you. The short answer, Louisa, is I am sure of it. You know, a lot of the places we've worked have been in immediate post-conflict situations, whereas emergency, like Doctors Without Borders, have gone in even when there's active conflict. But we know that once the guns are silenced, you can build very quickly centers like these that can make all the difference. In Haiti, for example, and I will finish here, Louisa, in Haiti, this hospital that was built after the earthquake became the national referral center for COVID because it had the staff, stuff, space, and systems required to take on a respiratory disease because of experience with trauma care. So I'm convinced.
Dr. Paul Farmer, thank you very much. Paul Farmer from Partners in Health. Rosella Micho from the NGO Emergency, Dr. Ahmed Al-Manthari from the World Health Organization. We also heard from Dr. Diana Atwine from the Ministry of Health in Uganda. So nice that she managed to break through the technical problems. And we heard that wonderful news of the conjoined twins being separated in Uganda as well. Thank you so much, all of you, for sharing your thoughts on Centres of Excellence. I will be back tomorrow for another In Focus panel when we'll be discussing the very topical issue of COVID and delivering the vaccine. Thank you, everybody, for watching and joining us today. Goodbye.
Thank you, Louise.
Thank you.